All right, hello everyone. So welcome back. In this part, we're going to begin talking about muscle tone, posture, and we're also going to talk about something called the Golgi tendon organ and the muscle spindle. So the first thing that we'll look at is something known as the Golgi tendon organ. The Golgi tendon organ resides in the muscle tendon, the tendon of the muscle, hence its name, tendon organ. And what this is monitoring and what this organ is detecting is something known as tension, all right? And so you can think of the tendon, the T in tendon, think tendon tension, all right? So what this is detecting is tension. And what it's really doing is it's helping to prevent our muscles from coming under such tension, our muscles and tendons alike, from coming under such tension that the weight of an object that we're trying to move or that we're holding would cause the tendon to rip off of the bone in something known as a tendon avulsion. So that's what we're trying to avoid here, right? And so what this is doing is this is detecting the amount of tension being applied to a muscle tendon unit by a particular load or by a weight, all right? And we have a couple of things, right? So in any reflex, in any kind of reflex arc, we have to have a couple of things. We have to have a receptor, we have to have a sensory neuron, we have to have a motor neuron coming out, you have to have an effector as well, all right? So in this case, where we're starting is we're starting right here with this blue receptor, right? So we're starting right here, and what we're doing is at this point, we are applying tension to the muscle tendon via holding something, right? We're holding something, we're trying to move something, we're increasing tension, all right? Say this tension is so great that there's a risk of a tendon avulsion, so tearing the tendon off of the bone. So there's a sensory signal that's sent along the sensory neuron through the dorsal root ganglion to the dorsal root and into the spinal cord, right? In the spinal cord, you're going to have a couple of things happen. You're going to relay this signal onto two different interneurons, right? One interneuron is excitatory, one is inhibitory, right? So let's first go to, and again, this is occurring in the knee here, right? So but this could very easily be occurring in the bicep or tricep or something like that, right? So we have one signal here. If we follow this kind of darker red one here, you follow this out, come out the ventral root to the spinal nerve and out, and we are inhibiting this quadriceps muscle, right? So the muscle relaxes and there's a decrease in the tension that's on the tendon, right? However, at the same time, what we're doing is we're sending an excitatory signal to the opposite muscle group. So in this case, the hamstrings, and the hamstrings are going to contract, right? And so in this case, we're decreasing the tension that was being applied on the on this quadriceps femoris tendon here. And so by relaxing this muscle, we decrease the tension. And by performing the opposite movement, which in this case is the hamstrings contracting, right, hip extension, you get a further decrease in the amount of tension that's being applied to a particular tendon. You could do the same thing if you're talking about the biceps, right? Imagine you're holding something heavy. You have tension being applied on the biceps tendon, and you'll have inhibition of the biceps, right? So that causes extension of the arm because you're no longer contracting it in a flexed position. And then you'd have stimulation of the and innervation of the triceps, right? Which would cause further elbow extension and thus cause you to decrease the angle between the upper arm and the lower arm. You're extending and you drop the weight and hopefully prevent the tendon from tearing from the bone, right? So this is a very protective feature, right? So you can see the same thing here. Here's our Golgi tendon organ. Within the tendon itself, you have a sensory neuron going back, a motor neuron coming out to the muscle, right? Now, the muscle that's being activated to contract is being innervated by an alpha motor neuron, right? The muscle that is being inhibited, the alpha motor neuron going to it would be inhibited, right? So in this case, you're inhibiting this alpha motor neuron, this dark one in red, but you're activating this alpha motor neuron coming out that's in this kind of lighter red or orange color, okay? So when you have this kind of pairing of contraction of one muscle and relaxation of another, there are two terms for this, right? So one is called autogenic inhibition, right? So if we go back here, if we go back for a second, this muscle, there are quads, right? The tendon here belongs to the quads, and we're ultimately inhibiting the quads, right? So that's called autogenic, auto referring to the same muscle, autogenic inhibition. We're inhibiting that same muscle. However, you also have something called reciprocal activation, right? So if you follow this one out, this orange neuron come out, we're now activating the reciprocal or the opposite muscle to contract, or muscle group, right? So here's our reciprocal activation. So you have autogenic inhibition and reciprocal activation. You have the two paired together, right? Okay, now the other structure that we'll look at here is called the muscle spindle, right? So when you think of the muscle spindle, think stretch of a muscle, right? So spindle, stretch, the T, the tendon, and Golgi tendon organ, think tension, right? So tendon, tension, spindle, stretch. Think of it that way. So here's our muscle spindle, right? So here's a spindle in here. These spindles are made up of intrafusal muscle fibers. If you're unsure of what an intrafusal muscle fiber is, go back and watch one of the previous parts of this lecture, and it'll tell you about what an intrafusal muscle fiber is. On the outside are extrafusal muscle fibers. So all of these out here. These are the muscle fibers that are actually contracting to cause the muscle to shorten or lengthen, right? So these are detecting stretch. So whenever you go to the doctor and the doctor performs the patellar reflex or tries to elicit the patellar reflex, what the doctor is doing is they're tapping on your tendon, usually your patellar tendon. That tapping of the tendon causes a slight but quick lengthening of the muscle, right? So you get a quick lengthening of the muscle, quick stretch of the muscle as a result of tapping on the tendon. And this sends a signal along these blue fibers here, these sensory fibers, back through the dorsal root, dorsal horn, into the spinal cord, and then out via the ventral root spinal nerve and out to the muscle. And what you get are a couple of things, right? One, you have the alpha motor neuron to the extrafusal muscle fibers, sending a signal to those extrafusal muscle fibers, causing it to contract, and you get a quick contraction. So in this case, you get an extension of the leg at the knee, right? If you ever go to the doctor and they tap it, your knee should swing out, right? Your lower leg should swing out in extension. So that's the alpha motor neuron. At the same time, you have these black gamma motor neurons coming in, and those are innervating the actual intrafusal muscle fibers, right? So again, alpha motor neuron to the extrafusal, gamma motor neuron to the intrafusal muscle fibers, and that causes those to contract, and that helps to maintain the tension, if you will, of these blue sensory fibers here, and so that they remain sensitive to additional stretches of the muscle, right? If you stretch the muscle and it gets shorter, you want to, or it contracts, you want to retain the sensitivity of that muscle to future stretches or future contractions, and so you have to contract these small intrafusal fibers as well to help maintain that sensitivity, all right? Okay, so you can see here just kind of a basic schematic of both of these. So the one on bottom is what we discussed first. You have the Golgi tendon organ, right? So you have tension, afferent neuron, interneuron coming out with the motor neuron, and then on top you have the muscle spindle, right? A stretch of that tendon. So really, to test the muscle spindle, you have to stretch the tendon, right? But you're not testing the Golgi tendon organ, but you're stretching the muscle spindle that's in the muscle belly, right? But same kind of basic loop, sensory neuron coming back out via the motor neuron, innervating the muscle, right? Now keep in mind here that this top pathway here, this is monosynaptic. You just have one synapse. This one down here, you have more than one synapse. So this is polysynaptic down here, all right? Okay, so what we'll talk about next are some disorders of motor pathways, right? So before we talk about disorders, we first have to discuss the terms signs and symptoms, all right? So a sign, and this is important clinically, a sign is something that you as the clinician will see, all right? So whether you're a nurse, physician, whoever, if you look at a patient and you can see certain things or determine certain things, that is a sign, right? A symptom comes from the patient, right? So if a patient says, I'm having a headache, okay, I'm having pain, I'm itchy, all those things are things that the patient is reporting to you. You can't directly see a headache. You cannot directly see pain. You cannot directly see nausea, right? You can see the effects of those things, but you cannot see them directly, Okay, for these, a sign, you yourself can detect an abnormal heartbeat, right? You can listen to breath sounds and determine breath sounds. You can take a blood pressure and determine all that, right? So if you as the clinician can ascertain and get that that result, that's a sign. If it's being told to you, that is a symptom. Okay, all right. So with our diseases and disorders, we have two general classes for our motor pathways. You have one that's called an upper motor neuron disorder, one that is called a lower motor neuron disorder, right? So our upper motor neuron disorders, we have some problem with our upper motor neuron, right? Those that are largely in the cerebral cortex. But remember, upper motor neurons could also be in the brainstem as well, and they really do extend down into the spinal cord, okay? So with this, you'd have muscle weakness, you'd have decreased control over some fine movements, and this is a result of a lack of innervation of the lower motor neurons from the upper motor neurons, right? If you have a disorder of the upper motor neuron, it's not going to be able to properly synapse onto the lower motor neuron, so the peripheral effects are going to be decreased weakness, decreased movement, things like that, right? Now, a big thing for upper motor neurons, this is really important for upper motor neurons, you get hypertonia and spasticity, right? Now, the reason, and this image over to the right, this is showing those signs. The hypertonia is referring to an increased tone of the muscle, and the spasticity is referring to the kind of rapid contraction of the muscles, all right? Or the uncontrolled contraction of the muscle. So the reason you get this is that ordinarily and normally, whenever you're not contracting muscles and whatnot, your upper motor neurons of those descending pathways kind of exert an inhibitory effect on the lower motor neuron, right? So they decrease the contraction of muscles. But whenever you have an upper motor neuron lesion or upper motor neuron disorder, you lose that inhibition. And so instead of having inhibition of those contractions and those movements, you get the movement. So you get hypertonia, you get spasticity, right? Now, another big sign, and again, this is a sign because you as the clinician could see it, is something called the Babinski test, right? So with the Babinski test, what you're doing is you're taking some kind of round, blunt, slightly sharp object, so like the end of a pin or something, and you're going to scrape it along the underside of the patient's foot, right? So if you look at this, what you're doing is you're taking a kind of blunt object here, scraping it on the underside of the foot. A negative Babinski sign is when the toes curl, all right? This is normal, right? You do it and your toes curl in. A positive Babinski sign is when instead of the toes curling in, they kind of fan out and the big toe extends, all right? If you see this, this is very abnormal, right? This is abnormal for everyone except really young infants, okay? Everybody should have a negative Babinski sign except for extremely young infants, right? If you see that, you can begin to think and begin to kind of get the idea that there may be some type of upper motor neuron lesion or some type of upper motor neuron disorder, okay? So you can see that here if you have access to the lecture slides. There are videos here that you can click on and play. But same thing, you're getting that muscle weakness, you're getting the hypertonia and the spasticity, right? All right. So here's kind of this is a graph showing, or a table rather, showing some disorders in which you can have some type of disruption of an upper motor neuron that leads to some type of loss of movement, right? So you can get quadriplegia, which is loss, partial or total, of all four limbs, hemiplegia, paraplegia, where you're losing either to one side of the body or in one or both limbs. And the level of the spinal cord that is involved will determine what type of paralysis you get, okay? Generally, the higher up you go in the spinal cord, the more widespread the paralysis is, right? So obviously, if you have a cervical spinal cord injury, there's a lot more below the cervical spinal cord than there is below the lumbar spinal cord, right? And so the higher up you get, the more potential things that will be involved, right? So this is why upper and high cervical spinal cord injuries are extremely dangerous, particularly for breathing, is because our phrenic nerve that arises from our cervical plexus, it comes from the cervical region and goes down to the diaphragm. So if you have a high cervical nerve injury, you're at risk for a decreased ability to ventilate and to breathe on your own. Okay, so very serious. Now, the other type of disorder is a lower motor neuron disorder, right? This, instead of happening to the upper motor neuron, is occurring to the lower motor neuron, specifically the alpha motor neuron, right? So the one that goes out to those extrafusal muscle fibers, okay? In this case, you can get things like paresis, atrophy, so overall weakness and disuse of the muscle. And because you are having a lack of innervation from the direct neuron that goes out to the periphery, instead of having hypertonia and spasticity, you'll have muscle weakness and you'll have hypotonia, right? So you'll have a decrease in the overall muscle tone. You won't see those kind of contracted fingers as you saw in the previous couple of slides, right? And then a big thing here for diagnosis is you would have a negative Babinski sign. You would not have a positive Babinski sign, all right? So different things here. You'd see very poor muscle tone, so hypotonia. We'll talk about this here in just a second. Bell's palsy, you can see in an infant, very poor muscle tone with respect to their limbs and with their head. And when you look at Bell's palsy in particular, Bell's palsy has to do with the paralysis of the 7th cranial nerve, which is our facial nerve, right? So cranial nerve 7, facial nerve. The facial nerve, we've said in previous videos that it innervates the muscles of facial expression, okay? So with muscles of facial expression, these are the ones that control your ability to smile, frown, grimace, raise your eyes, close your eyes, all of these different things, right? So with Bell's palsy, the condition occurs as a result of some damage to a facial nerve below the level of the facial nerve nucleus, right? So here's the facial nerve nucleus and the brainstem. Here's the level of the damage, right? So everything coming out from that, so if you look at your nerve lesion here, everything coming out, all of that is affected. So the lower face and the upper face. You can contrast that with what's called a supranuclear nerve lesion, or something like a stroke, in which only the lower part of the face would be affected because the upper part of the face actually receives innervation from both sides of the brain. So even if you have one side that's damaged, as you do in this case, you still get it from the other side, right? So the way to differentiate between Bell's palsy or facial nerve palsy and a stroke is you would look at the upper forehead. You look at the region of skin overlying the forehead. And so if you were trying to decide between the two, you could tell a patient, raise your eyes, raise your eyebrows and try to wrinkle your forehead, right? And if you see that they're not able to do that, as you see in this image, right? So note here, wrinkled forehead, nice and smooth forehead. And so this side of the face, the patient's right side, this is the region that is affected. This side over here is just fine, right? You can see corner of the lip goes up on this side, does not on this side. Big nasolabial fold here. You do not see that on this side. Wrinkling of the eye, no wrinkling of the eye, wrinkling of the forehead, no wrinkling of the forehead, okay? So in a patient with Bell's palsy, you do not have sparing of the forehead. You have a lack of innervation to the muscles of the forehead. In a stroke, if you told them to, raise your eyebrows or wrinkle your forehead, they would be able to do so, but the lower half of the face would be paralyzed, okay? So this is more serious than Bell's palsy, facial nerve palsy, something like that, okay? All right, so next you have what are called basal nuclei disorders, right? And these have to do with damages to some part of your basal nuclei or your basal ganglia, as they're sometimes referred to. And so you can have something called dyskinesia, achinesias, and hypokinesias, all right? So this has to do with poor, uncoordinated, atypical movement or a very significant decrease in movement. All right, so you can watch, there's a video here. If you have access to the slides, you can click on it and play it and look at what a dyskinesia looks like. You can also click on this video and watch it. And what you would see is you could look in the patient's hands in this region right here and his finger over here, and you see something called pill rolling. And his fingers will kind of roll in as if he was rolling something in his hands. And these are a result of some damage to the basal nuclei. All right. Now, you can have something that's relatively common, and you likely know somebody with it, called Parkinson's disease, right? So Parkinson's disease has to do with a disruption in the basal nuclei, right? And particularly a region called the substantia nigra, okay, which is kind of associated with the basal nuclei. So what you see are in the midbrain, you have these dark regions called substantia nigra. Literally translates to dark substance, okay? It's dark in here because you have melanin-filled neurons, and those are producing dopamine, all right? So these are producing dopamine, and dopamine helps to regulate the activity and the functionality of our basal nuclei, and it helps to reduce kind of extraneous, unwanted, involuntary movements, right? So when you have a breakdown in that substantia nigra, and you're no longer producing the dopamine, you now see those kind of excess movements, right? And so they may have a tremor at rest, so their hands may shake, you may have that pill rolling, slow voluntary movements, their speech may be uncoordinated, very stiff posture as well, and it's all a result of a loss in the dopamine production in the brain, right? So you can combat this by giving dopaminergic medications that increase the amount of dopamine available for the patients, but these are typically just a temporary fix, right? So Michael J. Fox, he is a individual who suffered a very early onset of Parkinson's disease, far earlier than what is typical, right? And so you can see it's relatively common in people getting older in age, so 65, 70, and beyond. And there can also be a young onset in individuals who are less than 40, but this is a relatively rare. It's not by any means the majority of the Parkinson's cases. Okay, so I think this is the last brain disorder that we'll discuss here. Huntington's disease. This has to do with a destruction also of some of your basal ganglia that have roles in coordinating movements. And so here you can see the ventricle, the lateral ventricles in the brain. Here you see them in Huntington's disease. They've become very enlarged. They're kind of compressing and atrophying the basal nuclei. And so you get poor control of voluntary muscle movements. Your intellectual faculties, your cognitive abilities can also begin to decline. And this is a progressive and generally fatal brain diagnosis. It's not something that has yet been able to be cured, right? Oh, I forgot we have cerebellum disorders as well. So let's do cerebellum disorders, and then we'll stop this part and pick up with our last part. So cerebellum disorders can have implications regarding balance and equilibrium, and so loss of coordination, posture imbalance, difficulty with coordinating your muscle movements, so how fluid and how smooth your muscles are. So remember, the cerebellum is receiving sensory input from the periphery, and it's also receiving motor input. And so some disorder in which the cerebellum is involved will likely influence your ability to produce smooth, coordinated muscle movements, right? So we will stop here and we'll pick up with the last part very, very briefly, talking about aging and how that can influence our motor pathway.